ketamine is hemodynamically stable. We've all said it, we've all taught it, we've all used it, especially when the patient looks like they're hanging on by a thread. But this latest RCT shows there's more cardiovascular collapse with ketamine and no statistically significant mortality benefit. So today we're breaking down the latest New England Journal of Medicine RSI trial, ketamine versus etomidate for intubation in critically ill patients.
And importantly, what do we do with this Monday morning in the ED or in the ICU?
We're going to talk about outcomes that matter, composites that might be a little bit misleading, and what actually changes practice if we are changing practice at all.
Let's get to it. Hey, Rebels. Welcome back to Rebelcast. I'm Mark Percy, and I'm joined here by Mark Ramsey.
What's up, everyone?
And the world famous Anand Swaminathan.
It's good to be here, guys.
In today's paper, KCJD et al., ketamine or etomidate for tracheal intubation in critically ill patients. This is hot off the press, lots of talk, lots of chatter about it from New England Journal of Medicine. We're going to keep it practical. We talk about the trial shows, where it's strong, where it's limited, and how it should change your RSI decision-making on your very next shift. Now, let's get into it. This is a debate that's been going on for years in ER and critical care. Etomidate, it's fast, predictable, minimal hemodynamic effect, but there is that adrenal suppression. There's ketamine, analgesic, bronchodilatory properties, stable, historically framed, and no adrenal suppression. I know Mark loves that. We've had signals in our prior data suggesting that ketamine might be better for mortality, like the most recent Bayesian meta-analysis came out in 2023. But just signals are not definitive proof.
I think that's exactly the thing that we have to stress is that what we have to this point is observational data that has said ketamine looks better. Maybe even ketamine gives you a mortality advantage, association only, but all that data is kind of messy. And every time that we look at that data, we say the same thing. I need a randomized control trial. I need to see the sickest patients getting the drugs because that's where we really care about it. We need that big, well-done randomized control trial, and that might be what we have.
Let's be honest, intubating is a really high-risk moment. I mean, whether you're in the ER or the ICU, the induction agent you choose can really meaningfully change outcomes. Even if it's a little, it can still be a very big deal.
All right, Swami, give us the details. What did they do in this trial?
There's a lot of buzzwords here that we like to see. Multicenter, randomized, open label, and we're going to come back to that later because that one's important. And this was in EDs and ICUs in adults over 18 undergoing tracheal intubation with an induction agent. There were some important exclusions. Pregnancy and prisoners, always excluded. We never get trials with those groups in it. We get that. But trauma was another big exclusion. We'll come back to that later. Immediate intubations where randomization couldn't happen. So those rare cases where you're like, I don't have time to do any resuscitation. We're just going for this tube. And then cases where the clinicians thought one drug was clearly indicated or contraindicated. That's a really important one, Mark.
Yeah, and the clinical equipoise in action. I mean, the results are applying to either drug is reasonable, patient. This is not your obvious extremes, and this is something to really consider as we talk more about this.
The intervention itself, also pretty interesting. So ketamine was given via this nomogram. You could give full dose, which they said was 2 mg per kg. You could give an intermediate dose, which was 1.5 mg per kg, or a reduced dose at 1 mg per kg. And etomidate had a similar nomogram, 0.3, 0.25, and 0.2 mg per kg, depending on how you felt about the patient and what you thought they needed. We're going to come back to that too, because that one's really important. Are those the right doses?
Yeah, so there were a good number of patients in this study. 2,365 patients were randomized, 1,176 to ketamine, 1,189 to etomidate. Really clean execution. I mean, greater than 99% got the assigned drug, and about 69% got rocuronium. About 95% used video laryngoscope, so pretty modern airway practice. And now for the primary outcome, at 28-day mortality, ketamine was 28.1% and etomidate 29.1%. That difference of negative 0.8% and the confidence interval crosses 0, so not statistically significant. Now for that secondary outcome, Mark, you mentioned about cardiovascular collapse, ketamine was 22.1% and etomidate 17%. The absolute difference of 5.1% was statistically significant.
Yeah, I think this is an important point. One is this is a composite outcome, and composites matter. Why don't you break that down a little bit for us?
Yeah, so the big driver here was that new or increased vasopressor use. So ketamine was 21.3% and etomidate 15.9%. That absolute difference of 5.4% was statistically significant. But now it's really important to note this. Systolic blood pressure less than 65 was close. It was 6.4% versus 5.5%, and that was not statistically significant. And now, no, because I had overlooked this as well, it's systolic blood pressure less than 65, not MAP, right? And then in cardiac arrest, it was 1% versus 0.8%, which was not significant.
This is important for us to tease out because the collapse signal is real, but it is a composite. And those three things are not necessarily equivalent. I mean, obviously, cardiac arrest, way worse than just I had to add pressors or titrate them up. SBP less than 65, I mean, that's pretty bad, right? I mean, I think we would all agree that's way too hypotensive, but still not as bad as cardiac arrest. So when we see hemodynamic collapse, let's just be really clear that doesn't mean that these patients all arrested. It means that they got an increased dose of vasoactives.
Yeah, I think that's really important that we highlight the fact that one, this is a composite outcome, like you mentioned, and composites sheerly exist just to drive down the number of patients required in the study. And look, this is a really hard study to do. It's hard to get 2,500 patients who are going to be intubated and who have sepsis and all the other things. It's not easy, which is why it's probably taken so long to do. The second thing I want to make sure we highlight for secondary outcomes is that studies are not powered for the secondary outcome. So these can only be hypothesis generating and should be used for a future study. Now let's move on a little bit. And Swami, why don't you tell us a little bit about the strengths and weaknesses? Because I think this is where we get hung up a lot.
Yeah, Marco, you said it, and I just want to repeat it. This group does really good airway research. These guys know what they're doing. They put together well done studies. This is a group that I point my residents to. I'm like, when you see these folks publishing, you're going to want to read the study. It's going to be well done. And we see a lot of things that we like: multicenter, ED and ICU, strong randomization with balanced baseline characteristics. The population is appropriately sick. That's the patient that we really care about this stuff about. Protocol adherence was really good, as Mark mentioned before, and follow up was excellent. So there's a lot of really good things that we see with this study.
Now, some of the limitations, though, it was open label. So not just bias being a real risk, but performance bias, right? So providers who were giving the medications know that that patient got etomidate versus ketamine, and that could also change their management, or they could seem to want to expect that hypotension or hemodynamic collapse. And that's kind of a really big component as we look at a component like new or increased pressors, right? Another limitation was that trauma was excluded. Now, we can't overgeneralize to those patients, but they are also sick too, and they often get intubated. And so you can't extrapolate the study to that patient population, nor some of the other patient populations that we had mentioned up earlier, like prisoners or pregnant patients. Additionally, many patients had sepsis, which does limit the generalizability as well. And they were powering for a 5% mortality difference, which may have been optimistic if the true difference is 1%. I mean, you'd need a way bigger trial to do that.
Yeah, agreed. I think the best evidence we have on this paper in the Bayesian analysis says that likely ketamine is associated with decrease in mortality, but we just don't have an RCT big enough that's going to show that. And 5% agreed is a huge number. I just want to hit on the point that you mentioned, Mark, because I think this is a really important point that regarding performance bias. We really don't know much about these patients regarding what they received besides etomidate and ketamine, and maybe they got a little bit more pressors. But there are so many things that could go into whether or not a patient is going to have a drop in their blood pressure or cardiac arrest. Did they get pre-oxygenated with BiPAP coming off the heels of the pre-oxy trial, right? That could affect it. Was there more resuscitation in IV fluids? Did they get blood products, antibiotics? I mean, the list goes on and on. So there's probably a little bit of confounding here and teasing out some of these things that we just don't know. But nonetheless, again, agree with you, really good study. And just again, to harp on the composite outcomes, I think we all agree cardiac arrest, and we titrated the norepinephrine up a little bit. These are not the same thing, and likely patients and families are not going to care if you gave them an extra bump in norepinephrine versus, my mom or family member died.
Yeah, that's a really good point. And I just want to go back to that 5% mortality difference they were looking at, because I think this has been one of the big critiques of this paper is how could we expect a 5% mortality difference with something like this? But there's a reason why they picked that number. These researchers kind of went back to the literature and said, what is the number? And also, what's the number that people want to see? What would change practice, right? This was a really important thing they did before is what would change an intensivist or an emergency doctor's practice to go to ketamine. And when they looked at that data, it said 5%. So that's why they targeted 5%. Like that all makes sense. Now, again, a 1% mortality difference, I think all three of us would say that's important. A 1% mortality difference for something like this, ketamine's not expensive, Etomidate's not expensive. That would matter to us. It would matter to patients. But they didn't pick that number 5 out of nowhere. They had a really good logic for why they did it. We can still pick bones about it, but they did have a reasoning for why they picked that number. I think that's important for us to note.
Yeah, I think also, Swami, if they would have picked 1%, I mean, I don't know because I haven't done the math, but I'm guessing they would
20,000
have had to have
patients.
like 20. Yeah,
They
right.
would have never given us
It would have
data.
made this
Yeah, exactly. And that's a
impossible.
pragmatic approach, right? Like, let's get some data. And so, at the absolute minimum, what this can tell us is that you're not going to see a 5% mortality difference. That's still really important, usable data. It just isn't everything we want, right? We're selfish. We want all of that information.
Yeah, completely agree. So this begs the question, and I think between all of us and Rebel EM, we've done these papers so many times, and I think this question comes up for me every single time. Does etomidate and ketamine, is there a pathophysiologic explanation to why either of those would decrease mortality at 30 days? I mean, I just can't fathom something that's in your bloodstream for like 60 seconds at the beginning of this intubation, especially since these folks are going to have a very prolonged course and Mark's going to be dealing with them for 2 or 3 weeks in the ICU. Is this one medicine that we're giving like 3 weeks ago really affecting 30-day mortality?
I think it's a great question. And it's why the composite secondary outcome is really important, right? Because, okay, so I can't show a mortality difference, but does it make my care of this patient easier? Does it make it simpler? Does it avoid some drops in blood pressure, which where that is a statistical number and it's not a patient-centered outcome? We all think that it's an important outcome to see. So, yeah, I think it was a lot to expect a single dose of medication to have that large of an effect. At the same time, we did have data coming up to this, observational data, that said there was a real difference in mortality with what agent you intubated. So there was a reason for us to pursue this idea.
One thing I wanted to kind of include was like, on the ICU side of things and in the inpatient, if a patient codes and has a cardiac arrest, it's never in the back of our minds to be like, well, what were they induced with? Right? What medication was it that they got? Because that could be the reason, and I think that also is a testament to the point of that care around induction wasn't fully standardized. I mean, there's so many factors that go into just that alone, and then not to mention the care for the 28 days while they're in the hospital was also not standardized. They could have gotten so many other things or so many other complications could have happened that it's really hard to just pin this induction agent as like that was the reason.
Yeah, absolutely. Yeah, and this is really important to look at. So, etomidate and ketamine, neither one of these intrinsically causes hemodynamic instability. Okay, etomidate we know is hemodynamically stable, ketamine hemodynamically stable. We'll come back to that because there are some people who tell you that maybe it's not, but in general, the agent itself is not causing the hypotension. But what we do know is that any induction agent in a patient who is stressed is going to potentially cause hypotension, hemodynamic class, poor perfusion, because it's taking away that patient's intrinsic catecholamine drive, right? By inducing them, we take that away. So it doesn't matter what agent we use, all of them are going to have that effect, but these two agents don't intrinsically have that effect compared to something like propofol, where we know that propofol vasodilates, it is a cardiac depressant, and so it intrinsically can drop blood pressure. And then on top of that, it's also stealing away those catecholamines the patient has. So all of these agents can cause hypotension. When we look at the individual ones of why this might have happened more with ketamine than etomidate, there are a couple of things to consider. One is that ketamine does have analgesic effects. That might have had a more profound relief of that catecholamine surge that the patient has than etomidate does. And some people would say, well, etomidate really doesn't have any analgesic effects. Do we think it's a good idea to intubate patient without any analgesia, right? That's a separate question to get into, but ketamine does have that, and we do have to think about that part of it. The other thing is the dosing here, and we kind of alluded to this up front. The standard dose was 2 mg per kg for ketamine, down to 1.5 in the middle dose, and then down to 1. I don't know about you guys, but if I have a patient who is hemodynamically tenuous, I'm not reaching for 2 mg per kg. In fact, I never use 2 mg per kg of ketamine for intubation. 1.5 is kind of my standard dose. And if the patient is hemodynamically compromised in any way, I'm usually going with like 0.5 mgs per kg of ketamine, maybe even less is enough to get your induction. So I think that is one of the things that we can kind of pick a nit with is that the doses might have been too high. And honestly, even for etomidate, it might have been too much etomidate as well. And then this brings us back to that blinding part of it, right? This was an open label study. So people might have been like, okay, we're randomized to the etomidate arm. Maybe they resuscitated more before they gave that etomidate for induction. Maybe they were convinced that ketamine really isn't going to drop blood pressure. So I don't have to overly resuscitate this person before intubation. But if you had gone with just two dose strategies, right? 1.5 mg per kg of ketamine versus zero point 0.5 mg per ketamine if they're hemodynamically unstable, that might have allowed them to do blinding and would have taken out some of these issues.
Yeah, I mean, that's a huge point about the blinding, right? I mean, you don't know what led up to right before the medication was given. So that's the very first point. And then the other issue too is like that pre-intubation resuscitation really does matter. I mean, how like what fluid pressure choices are you doing? And the timing of it all play a role. Now, one kind of point I want to emphasize is that I'm in a unique situation where I give ketamine pretty frequently in my ICU for procedures. Just this past week, I did a cardioversion 2 times and I used ketamine. Now, granted, it's not induction for intubation, but my anecdotal experience with this is I actually see a lot more hypertension with ketamine, which is so strange because I've been trying to convince my nursing staff to use ketamine a lot more and to make it more readily available. But then when I give it, they're like, whoa, they're like really hypertensive. And I'm like, yeah, don't treat it. It's going to come down eventually. So I was very surprised to see the hypotension. And then when I intubate, I've actually become, I want to say, a little maybe biased or swayed for that hypertension. That when the patients are hypotensive, I have a feeling that they're going to become hypertensive from my prior experience with the ketamine. And I end up giving it in those hemodynamically unstable patients, assuming it's going to be either neutral or go slightly hypertensive. So at least my anecdotal experience is different. And that is also plays a huge role in that open label design or that performance bias that occurs with this open label design study.
Yeah, Mark, I'd be interested to hear what you think about this because you're talking about more ICU patients getting that hypertension. I give them a ton of doses of ketamine, both for procedural sedation as well as for intubation in the ED. I don't see a lot of hypertension, and that might be in big part because these are patients fresh off the street who haven't had any resuscitation, any care provided. They are stressed, their catecholamines are expended. And so the ketamine's not having an effect on their blood pressure because they don't have any more catecholamines to get released by that ketamine. Whereas it might be a little bit different up in the ICU. Not saying that your patients are like chilling and they're okay, but it might be a different subset of patients of why we see that. So I'm not surprised to see the hypotension with the ketamine. And this kind of, this is a little bit outside of the paper, but it comes back to why we often say, like, we're going to resuscitate aggressively before we intubate, even if their pressure looks okay. I'm going to have my norepi at bedside, if not running actively, because we know that these patients are kind of hemodynamically stressed and it's not going to take too much for them to drop a little bit. So I think all of this, in a lot of ways, tells us that what we have been talking about for the last 5 to 10 years of resuscitation prior to intubation, having your vasoactives ready to go, having that push dose of epi ready to go, it was all the right thing to do. It tells us that, and I think that's important. It just really helps us, or it makes us question how much hypotension we get with ketamine. And again, Marco, you pointed this out. It was a secondary outcome. It's hypothesis generating only. But we also look at this as clinicians and say, am I really going to get a better study? Is this the data that I'm going to have to use to advise my clinical practice? And let's be honest, it probably is. We're probably not going to see a study of 2,500 patients, double blind, randomized control, multicenter to ketamine or etomidate, looking at an outcome like hemodynamic collapse as a primary outcome.
Yeah, to your point about having vasopressors readily available, that just like even more reaffirms to have everything set up before you do any kind of procedure. I mean, whether you're using a checklist, whether it's a mental checklist, a physical one, doesn't matter. You should always have every possible item that you'll need in the event that there could be complications or things could go wrong. And I feel like this paper like really reaffirms that and really takes home the point of like make sure you're prepared for whether it's really, really severe hypotension or really severe hypertension. I mean, just have something ready.
Marco, before we move on to kind of like how we incorporate this into our clinical practice, I just want to point out two other things that we have to consider. One, again, comes back to that dosing. This was done based on actual body weight, which, a lot of folks will say we should be using ideal body weight for the dose of the induction agent. So maybe these patients were getting much larger doses than we normally would. Most of this study was done in Minnesota, if I remember correctly. For those who are listening to this outside of the United States, Minnesota is kind of the middle of the country. And yes, I know all Americans are obese. Minnesota might have a little bit more obesity than where the three of us work on the in the Northeast. I don't want to malign any Minnesotans. I think they're going to come at me pretty hard. We know Jenny Beck Esme's from Minneapolis, so she might be hitting me pretty hard on this one. But it is something to consider. Were we using too much of that induction agent because we were using actual body weight? And the last thing, and this comes back to that open label design, is the researchers have been pretty honest about the fact that they were not big ketamine enthusiasts going into this study. The three of us are. The three of us, I think, are relatively open about our love for ketamine, that we really like using it. That might actually have colored some of this because it's open label. And I'm, again, not maligning the researchers. This is a great group, it's a great team, but you just don't know how that stuff seeps into your subconscious when you're doing your resuscitation, when you're doing your care. And another reason why, if they could have blinded this, I think we would have had so many more answers.
Swami, I just want to highlight 2 points before we kind of take this home. And the first is, we're recording this just a few days before the worst snowstorm in the Northeast, and maybe they say decades, but I heard in Minnesota they just call that Tuesday. And then the last thing I want to say is, I think you hit a point in one of your previous comments just a few moments ago, is that the patients that are being intubated in the ICU are not the same as those patients being intubated in the ED. Some of the information that was buried in the supplement was that more patients who received Etomidate for intubation were intubated in the ICU, and those patients were also more likely to have pre-intubation pressors compared to ketamine, and more folks intubated with ketamine were likely to come from the ER. And again, just to highlight that these patients are not the same. Patients being intubated in the ER, likely we don't know much about them. We don't have any diagnostics back yet. Perhaps if it's a crash intubation, we may not even have the time to set up some of those things like pre-intubation pressors and some of these other adjuncts that we would often use. So just one more thing to say, preparation is key, but maybe these patients, there are some subtle differences that are worthy of exploration and thinking about before you throw the baby out with the bathwater.
And I think the other point to highlight is just, especially on the inpatient side of things, they are just not familiar or comfortable with ketamine. In many of the units I've worked at, when I say ketamine, it is like somebody needs to go to the plant manufacturers to get me the drug. It is very difficult and very problematic. And I think as more of us EM folks who are trained and cross-trained in different areas, introduce ketamine to the non-ketamine believers or people who are less familiar with it, I think that's going to change. But in the meantime, I'm not surprised that Etomidate is more frequently used in the ICU setting or inpatient setting versus ketamine.
I don't think we're getting rid of it. I don't think I'm moving away from ketamine, but I am kind of thinking a little bit more carefully about this whole thing. What we have to highlight is the primary outcome. No statistically significant mortality difference, which means not to throw ketamine away, but maybe it wasn't giving you as much of a benefit as you thought it was, but you can still go ahead and use it. There may be a smaller mortality benefit with a larger study. We might find that. We don't really know, right? We can hypothesize all we want. We're never going to get that answer until somebody does that larger study. But I don't think we're going to throw ketamine away at this point.
Yeah, and it does tell us something practical, right? Etomidate is an absolutely reasonable first-line medication if you're intubating critically ill adults. And it actually might be even preferable in those who are, transient hemodynamic instability, or if you are trying to decide between the two, if you go towards Etomidate first, it's not the complete end of the world.
Marco, let me just stress one other thing here. We all remember when they tried to take the Etomidate away from us because of that adrenal suppression. We don't see increased mortality here. Most of these patients were septic. But I think what that speaks to is that we were probably more likely to get steroids on board early in these patients if we were giving them Etomidate. And I think we've kind of just understood, okay, there's a transient adrenal suppression. I'm going to be more likely to give this patient steroids, and that's just going to take it out of play, and their adrenals are going to bounce back. So if you are an Etomidate person, you're like, I trained with Etomidate. I've used Etomidate 150 times, 200 times. I love Etomidate. I don't think any of us can tell you to stop using Etomidate. If you're a ketamine person, I don't think any of us can tell you to stop using ketamine. But I think we can say, in the patient with sepsis, in the patient with marginal hemodynamics, do your great resuscitation before, and then you might want to consider using Etomidate instead of ketamine. But even that is stretching the data a little bit.
And one thing I want to highlight too is to that point, if your shop is like an Etomidate only place and they're so familiar with that and that's all they use, regardless of what you as the provider use, because you might work at other sites, then go with Etomidate. If they are, everyone's wearing awesome ketamine shirts and team ketamine shirts and everyone loves ketamine, then great, then use ketamine. But don't deviate from what the rest of the staff is kind of prepared and used to, because that could cause lapses in the preparation needed for when complications occur.
Fellas, I don't even know if I have anything to add to that. So I appreciate you both. And before we say goodbye, I would love to do a quick hits rapid fire. This is how I do it. You guys game?
Yeah.
Let's do it.
All right. Mark, this is your first move. Septic shock, on the edge, borderline blood pressure, have to intubate. What are you doing?
Yeah, I would do Etomidate. I mean, I would definitely have pressors ready. I would optimize hemodynamics first, and then again, make sure, in addition to those pressors, you have all the other things, fluids, I would maybe even pads on the patient. Just make sure you have everything ready.
I don't really have any nits to pick with that. I think Etomidate would be totally fine there. I probably would also hit that patient with steroids if I haven't already done it. But I work in a training place, and if my resident's like, I want to use ketamine, probably not going to fight them on that either, because I just don't think there's that much of a difference.
All right. Next up, Swami, you're first. Status asthmaticus severe bronchospasm.
All of us are going to see ketamine here, right? I mean, I don't even know how strong those bronchodilatory effects are of ketamine, but there's something. So I'm probably going to use ketamine here. The other thing is that I might have used ketamine already to facilitate non-invasive for that patient. It's easy enough for me to hit them with a dose to facilitate non-invasive and then give them that full dissociative dose to intubate them.
Yeah, I would agree here. Ketamine, super great tool. I mean, you get those bronchodilatory effects. I mean, it just makes so much sense to use that.
All right, Mark, you're up next in this one. Cardiogenic shock, critical aortic stenosis, scary physiology. I think you probably just call this Wednesday, though, in the CTICU.
Yeah, I mean, this is like my wheelhouse. So totally Etomidate, but I am thinking about, definitely like awake techniques, depending on the scenario. I've had multiple of these patients, and the last thing I want to do is give them something that could really rock the boat and then add further, fuel on the fire by adding pressors that I think might complicate their case afterwards. So I would probably do Etomidate to start. I have given ketamine in some of these situations, and I've seen it go south pretty bad. Again, anecdotal evidence, but still, I would probably start with Etomidate.
I'm going to definitely defer to Mark on this one. I think Etomidate would be totally fine. The one thing that I would say is that if I wanted to do this patient awake or semi-awake, I might do a ketamine facilitated, right? Just give a small dose of ketamine to facilitate my airway manipulation, my intubation, not paralyze them at all. That might actually be the win in this patient. So you can see these things are really complicated as to there isn't an ideal situation. It just depends on what you're comfortable with. A lot of folks I work with are not comfortable with ketamine only intubation, and I'm not going to make them do one. Not in a patient who's tenuous like this, but I'm pretty comfortable with it. So I might just do a tiny dose of ketamine and intubate them without a paralytic.
And to quickly add to that point, again, there's a lot of factors to consider. Like, oftentimes, if this is happening and I'm in my CTICU, the surgeon will descend from the ceiling tiles and be like, "What's this ketamine shit you're trying to do?" Right? And you're just like, "No, let me just trust me. Like, we can do this." Right? And so that is something obviously to consider. And if the people are not used to that, don't do it.
Thanks again, fellas. So let's just recap. No statistically significant difference in 28-day mortality between ketamine and Etomidate. There was about a 1% absolute difference favoring ketamine, but it's uncertain. Ketamine had more cardiovascular collapse, driven mostly by new or increased vasopressor use, not systolic blood pressure less than 65, and not cardiac arrest. This shouldn't make you abandon ketamine, but it absolutely supports Etomidate as a continued first-line agent. Mark, Swami, you guys are the man, and thanks as always.
It's our pleasure, man. It's always awesome to be on here talking critically ill patients and intubations.
Yeah, great topic. Thanks for bringing us together to do it.
Rebels, if you enjoyed this episode, share it with a friend on social media, and be sure to check us out everywhere you get your medical information and social media. We're on Instagram, we're on X, formerly known as Twitter, we're on Blue Sky, we're on Facebook. Anything else we're on, Mark?
I think LinkedIn, and I'm pretty sure, I don't know if anybody uses LinkedIn, pretty sure.
All right, and check out rebelem.com for the full write-up. And thanks again, fellas.